Hi, everybody. First of all, I'd like to say to all of you out there, happy National Nurses Week. We're proud of what you do. Thank you for all that you do, and you matter. Today, I'm going to be talking about ostomy care tips and tricks for your practice. So, happy National Nurses Week. We'll start with a land acknowledgement. And we acknowledge that we're holding this gathering on the unceded territory of the Wolastoqey, Mi'kmaq, and Passamaquoddy's people. This territory is covered by the treaties of peace and friendship, which these nations first signed with the British Crown in 1726. These treaties did not deal with the surrender of lands and resources, but recognized the Mi'kmaq and Wolastoqey title and established rules between nations. We pay respects to the elders past and present and descendants of this land. We honor the knowledge keepers and seek their guidance as we strive to develop closer relationships with the Indigenous people of New Brunswick. Today, we're going to be talking about tips and tricks for care. My other bag is a Gucci. Now, this is a lady that I've seen a client years ago and troubleshooting ostomy issues. So you'll come across this in your practice. We'll go over the different types of stomas this morning or this afternoon, whenever you're watching. We want to increase your knowledge on troubleshooting ostomy issues, what we're looking for, what we see, and most importantly, how we can manage it to better improve their care. And we want to improve your skills for ostomy care. So we're just going to do a quick refresher on the different types of ostomies. There's three main types: colostomies, ileostomies, and urostomies. Colostomies tend to be on the left side and they involve the large bowel. And you can see the large bowel there in the picture. Ileostomies tend to be on the right side and they involve the small bowel. Urostomies tend to be on the right side, and that's when the bladder is removed and they create an opening. So a colostomy, just to give you a better picture, is where the large intestine is diverted through an opening in the abdomen. It's usually the left side, and that opening is what we call as a stoma. In Canada, about 13,000 ostomy surgeries are performed every year. It's estimated that there's over 150,000 Canadians with an ostomy and growing. Why do people get colostomies? It tends to be mainly number one is cancer, trauma, inflammatory bowel disease, congenital malformations, abscesses, and my dad had one from complications of diverticulitis, so you'll see that as well. Your output with a colostomy, and this is really important to note, is tends to be more formed or mushy consistency of stool. So it'll vary from mushy to formed stool. Flatus or gas will also be passed through the stoma. The ileostomy, note the location, it's going to be on the right side of the abdomen, and the output is much softer, it's liquidy, surgically created through the end of the ileum or small bowel in the intestine, again brought through the surfaces. The reason: congenital malformation, cancer, trauma, inflammatory bowel disease, and that includes your ulcerative colitis and your Crohn's disease. Your output or affluent, it tends to be liquidy or pasty consistency with gas. And the drainage may change in color in response to certain foods. Also, I find if I'm encouraging my patients to drink more, we'll see what goes in must comes out. It tends to be more watery. The waste or stool contains residual digestive enzymes, so it might be irritating to the skin. So that's why with an ileostomy, we have to really watch the skin around the stoma. And you can see the loop ileostomy in the bottom picture. The top is a permanent ileostomy. It has one opening. The lower one has a loop, and you can see on both sides. And those tend to generally be reversible. They'll create a loop ileostomy as they take out the cancer, allow that bowel to heal, and then they'll reverse the procedure, which tends to be about half of the time in the OR and half the recovery time. The next one is a urostomy, and you can see in the top right-hand corner, it's working well. And the urostomy, it's generally when the bladder is removed and the normal urinary structures are bypassed. So it's a surgical opening that creates a stoma, and it's made to move the urine away from the bladder. There's several procedures to divert, and we'll often hear of an ileoconduit, which just means urostomy, ureterostoma, which is a stoma created using a ureter, and less frequency is a continent urostomy or an internal pouch. And the number one reason that people get a urostomy is for cancer. Other reasons, less common, is congenital malformation, spinal cord injury, damage or injury to the urinary tract, or a neurogenic bladder. So your outcome, the urine can be pinkish initially after surgery, but you'll always see a little bit of mucus shreds in the urine. And can you think of why you might see that? If you look in the picture, we can see that you've got your kidneys, your ureter, and then we've used part of the bowel to bring out the stoma to the outside of the body. So when you're using part of the bowel, you're going to have some mucus in that urine at all times. And people will say, oh, that really bothers me. And I do find that if we drink a little bit more water, it tends to clear a bit, a little bit, but very normal to have a mucus in your urine. You can see in the picture on the bottom right side, you see two stents. And that is a fresh urostomy patient post-op, and they'll have the stents in. It all depends on the urologist, how long they keep them in while things are healing, and then they're removed. Okay, so if we're going to assess our stoma, what should that stoma look like? It should be soft, moist, red, pink, and shiny. And if you take your tongue and roll it around your mouth, the inside of your mouth, that's exactly what your stoma is going to look like. It's going to be moist and pink all the time. The size of that stoma depends on whether it's a urostomy, colostomy, or ileostomy. They can be round, they can be oval. If they're looped, they tend to be a little bit more oval. The shape we've talked about, the protrusion. Sometimes when they're doing a colostomy, which is going to be on the left side, the large bowel, it can be a little bit more flatter to the skin. But an ileostomy on the right side, because if we think about the ileum and the enzymes that are involved in the output, we need some height on that to have a good hold. Protrusion just refers to how much it comes out from your abdomen. So we'll say it's got good height. So good height means there's enough of that stoma showing on the outside of the body for a good hold. Affluent, the term affluent just refers to our output. And then peristomal skin, as it sounds, is just the skin right around that stoma. So I love this picture. This is a picture that my former colleague Cassie Esliar and I used for teaching for probably 20 years, and we still love it. And it's just a great little visual of what you will see in your practice. You'll see sub or retracted, and the first top is almost inverted. And I'm going to show you some pictures of stomas that have that. The next one is flush, and you can see it's pretty flush to the skin. And then you've got your right down to prolapsing. And just a little hint, what do we do for prolapsing? Unless it comes out a significant amount that it fills up your bag, the surgeons will tend to just get a longer bag for it. Sometimes they do have to take them back and stitch it back a little bit. So you can see in the second line, a new stoma. The new stomas are always edematous because they just had surgery. So it'll be swollen, and I'll say to the patient, you're looking at that stoma right now, and it looks really big and swollen, but I just want to remind you that in 6 to 8 weeks, that stoma is going to shrink down substantially. And you can see in the next picture a mature stoma. The loops we've talked about already, and the shapes. Double barrel, we don't see them. I haven't seen them in 20 years of practice plus. A fistula, that's what we don't want. That's that abnormal opening to the outside of the skin. And unfortunately, that's a rare, thank goodness it's a rare complication. And sometimes we'll see a wound. So I'm going to ask you, what part of the bowel would a colostomy be placed? Would it be A, the ileum, B, the colon, C, the jejunum, or D, none of the above? Take a minute to think about it. And it is indeed the colon or large bowel. Okay, so if you got B, you got that right. I wish we had prizes. So why is it important to measure? So if someone comes into your care, whether you're working at a nursing home, a clinic, in hospital, or in the community, in the patient's home, when I see that person for the first time, I take my measuring card, and they come in various sizes, and every company has them. And I just want to, I should have mentioned this in full disclosure. I'm not affiliated with any company. People will sometimes say to me, "Oh, product would you recommend?" I'll say, I recommend the product that gives you good hold and that you like. So these are called stoma guides, and you can see the different circles. So when you take that appliance off, you're going to put this right over that stoma and measure the size of it. And we tend to measure in millimeters, unless it's a really flat or oval one, then I'll take my ruler and I'll go width and length. But we generally will use this and we'll put it right over the stoma to see which one fits. And why is that so important to measure? Well, it's a big deal and it makes a big difference because if you measure the stoma, let's say initially it comes back from surgery and it is 45 millimeters, this one right here. Well, the chances of that stoma being 45 millimeters in 6 weeks from now is very, very rare because it's going to shrink. So if you're using a cut to fit appliance, and you're cutting it at 45 millimeters 6 weeks later, chances are that output is going to get on that skin and cause damage to the skin. So it's very important. And then I'll write it down and I'll let the person write. I encourage them, not let them, excuse me. I have them write it down as well because it's their stoma, it's their ostomy, and we want to teach them how to manage it. And then you have it for comparison later on. Okay, so a question, how often should patients or residents be changing your appliances? Is it every day, every 3 days, 5 days, or 7? And is there a time when you need to change it immediately? The answer is how often it should be changed is generally we say by day 7, it's recommended or the maximum time for the flange to be worn on the body. And the reason why, and you can see this one, is that material, excuse me, what that's made of, it tends to start to wear down a little bit after 7 days. Now, having said that, I know a gentleman who participates in our local support group who brags that he gets 14 days out of his appliance. We do not recommend that at all. 7 days at day 7, we should be changing because we don't want that wafer to break down and cause skin damage to our skin. Some people will tell me, Nancy, I change it every 5 days because that is my comfort level. I'll say, does your skin look good? And if their skin looks good, it works for them, then that is appropriate for them. We always go patient-centered care. What do they want? What works best for them? We aim for a minimum of at least 3 days wear time. So I have a lady in the community, and she's given me permission to share her story. Her surgery was very complex. She ended up having terrible, terrible leakage around, and then your quality of life goes down because some people who don't want to eat, they can have isolation. They don't want to go out for fear it's leaking, etc. But we aim for people who are high risk of leaking, and hers is because it's so inverted, it leaks terrible. You're going to see some pictures later on. We aim for, if we could get 3 days wear time for this lady, we would be over the moon. But generally speaking, people should be changing their appliance every 7 days. But 3 to 4 days is perfectly accepted wear time. We're all different. Okay. So the next question is, what is stoma adhesive paste used for? And I'm going to cover the name of this company. And what it is, it looks kind of like toothpaste and it comes out like toothpaste. And is it used for cleaning? B, removal of the appliance? Is it used for caulking or filler? Or none of the above? What do you think? If you have chosen caulking or filler, you've got it right. So the paste we will use to seal it because we all don't have beautiful flat abdomens. If I lay down perfectly flat, my abdomen is straight as the board, beautiful. But when I sit up, like I'm sitting up talking to you today, I have what I call my carbohydrate rolls because I love bagels. So we tend to have some rolls and creases in our skin. And if I was wearing an ostomy, chances are I might need to use that a little bit of caulking or filler, the stomaadhesive paste, and I'll cover that name, as a filler to get in those creases. We want to seal those creases so they do not leak. Okay, the next question is, all ostomies are permanent, true or false? That would be false. An ostomy is a surgical procedure that involves the creation of an opening in the body to divert flow of waste and fluids, but not necessarily permanent. My father, he had his because of diverticulitis. He was able to have it reversed later. Other people, if there's a cancer diagnosis, sometimes they're eligible to have it reversed later after all their treatments are done. And then we have some people who, even when they are temporary, choose to keep it. They'll say, my quality of life is so much better since I have this ostomy and stoma. I can do activities now. I'm not going to the bathroom all the time, et cetera, et cetera. I'm choosing to keep it, even when they've cured the disease. So again, everybody is different. Okay, true or false? The ileocondyli or urostomy is created by using a portion of the ileum to allow stool to pass through. True or false? The answer is false, because when we think of an ileocondyle, we know it's a urostomy. So it's not to allow stool to pass through. It's connected to a urostomy bag, allowing urine to be collected externally. The next question for you is, when someone has red, I have spelt that wrong, I apologize, denuded skin around the stoma, what products are used to treat the skin and in what order are they used? A, stomaadhesive powder and paste. 2, no sting skin barrier spray, and that can come in a little wipe as well. 3, stomaadhesive powder and no sting skin barrier spray. Or D, stomaadhesive paste, powder, and skin barrier spray. Okay, I'll give you a minute to think about that. It's actually C, stomaadhesive powder and the no sting skin barrier spray. And again, as I said, it comes in wipes as well. All the companies that sell ostomy products have barrier sprays and wipes. And the no sting is a reminder to us as nursing that there's no alcohol in it, so it will not irritate the skin. And that's important. Okay, cleaning and changing of the appliance. My first question to you is, if you had a colostomy, does it matter what time of day you change it? No. Ileostomy might be a little bit more important because ileostomy with the colostomy, you tend to go 1 to 3 times a day and you will have soft formed stool, usually, generally. And ileostomy is going all the time. And we encourage people, it's not that you have to, but it can make it easier to change your ileostomy before you eat first thing in the morning. And why? Because it's less active. I have one gentleman that came in to see me. He was having leakage problems around his ileostomy. And he said, don't worry, Nancy, I didn't eat. And it was the affluent liquid stool was coming out like crazy. And I said, "Oh, dear so-and-so, are you sure you didn't eat?" He said, "No, Nancy, I only had 2 big cups of coffee." Well, we know what caffeine does for our bowels sometimes, and it certainly indeed made it very active that morning. So with ileostomies, we tend to recommend to do it before you eat first thing in the morning. And with urostomies, again, that's a person's choice. How often do we change them? Usually, generally once a week, unless they're leaking, change them immediately because we don't want anything around that peristomal skin to irritate or anything. So we would change it immediately if it's leaking or early in the morning if it's an ileostomy. Okay. And I will generally tell people if people are getting 7-day wear time, they'll say, pick a day where it's a morning that you're not doing anything, don't have anything planned. Make that morning time all about you and stick with that routine of, and I'll have people who will say to me, Nancy, I change it every Saturday morning faithfully, or I change it every Friday morning faithfully. Again, it's whatever works for the person. And but if they're getting 7-day wear time, stick with the same day. So how are we going to remove that appliance that's on that body? So I'm going to put it on my arm to show you how we should be moving it, removing it. And to remove it, you're going to, maybe I'll put it on my shoulder. You're going to use one hand to hold the skin and the other hand to slowly lift it. And I start across the top. And again, as I'm going, I move my hand around. And the reason why we do that, one hand holds the skin, so you're not pulling right off, because I've seen major skin stripping from people. Oh, I've got that. And they take that barrier, as I say, rip it off. And then their skin will be red, irritated, and sometimes they'll remove skin. So hold down the skin with one hand as you gently remove. Okay, there are adhesive removers if you want. All of these products are costly, so it's not necessary if their skin is intact in that you need, oh, I need a adhesive remover to take my appliance off. Nope, you don't. If your skin looks good, less is more, we tend to say. Okay. So preparing your supplies, whether you're using a 2-piece system or a 1-piece system, we recommend that you warm the appliance. So I'm going to get both, and you can, with the appliance, this is again, ignore the company name. We'll put that, sometimes we'll put it underneath the arm. Some people will put it underneath their legs. Some people will sit on it. And the goal is to warm that appliance. And why? Because it helps it adhere, stick better. And after it's being placed on the body, we'll get them to put a hand over it. Some people will put a warm blanket. Some people will, I don't recommend hot water bottles. We've seen burns from them. We'll warm it up. But again, even just your skin and body heat, and keep that on for about 5 minutes afterwards. So keep it simple. When you're changing your appliances, the less steps involved, the easier for the person and more cost efficient as well. Because these products, if you're not covered through your health insurance plan or government assistance and you're paying out of pocket, it can be quite pricey. My father, who was passed now, was a retired dairy farmer, and he didn't have any health insurance because they didn't need it, and he was paying out of pocket for his supplies. And he was very lucky. He got about 7-day wear time. So average cost for him was about $150 a month. If people are running into leakage issues, etc., it can go way up into over $1,000 per month. So keep it simple. The less products, the less steps, better. Okay, and we'll go over some more tips in a little bit. So troubleshooting ostomy care, unfortunately, more than 80% of patients will experience complications of their stoma or peristomal skin within 2 years after surgery. And that's a high percentage of patients. These patients need to be seen quickly, and the healthcare workers need to be knowledgeable about the ostomies and the complications. And this is where you and I come in. That picture there is a dear friend of mine, Kathy Esligar. She taught me everything I know and is someone that I highly admire. She's retired now, but she did work for over 40 years in nursing and the last couple of decades in wound and ostomy care. So positioning counts. I have, this is a picture I have of a patient, and I thank all my wonderful patients for sharing their stories and sharing their pictures so that we can all learn together. In the first picture, he's laying down, and in the second picture, he's sitting up. So people will ask, what position should I be in when I put my new appliance on? It can be whatever works for the person, but we tend to recommend sitting up now so that we can see those creases. And you can see in that second picture where certainly you can see half the side, that the stoma is half the side, and it's almost tucked in. So we're going to need some help to make that stoma be upright again so that the stool doesn't go into those creases and comes out into the collection bag. So positioning does count, you bet. Okay, now we're going to go into some skin issues that you might see in your practice. The first one is peristomal adhesive, medical adhesive related skin injury. And that's an alteration in your skin integrity with erythema and other skin alterations such as skin tears or erosion after removal of the appliance. And they are quite prevalent, but people don't tend to report them, so we were not really quite sure what the stats are. So again, it's a matter of educating the person to take that off gently, hold the skin back to minimize skin stripping. And just that little simple trick really does work. The next one we're going to look at is inflammation or denudation of the skin adjacent to the stoma. And that's it tends to occur because stool or urine has been around it. So we know what loose stool will do to our skin. It will burn it, it will make it red, inflamed, even open. So we want to protect that skin. So we're going to talk about several peristomal complications. And if we look at that stoma right in the picture there, you can see that there's little ulcers around her stoma. And it looks like her appliance is a little bit too tight too. It's pressing into her skin, isn't it? So we want to wash that redness. We want to treat that redness. And we want those little sores to heal. So you would clean it good. People will say, what do I clean with? Warm water, no soap, no baby wipes. Baby wipes and wipes tend to leave a little bit of a residue. And then you pat it dry. And I had one gentleman say to me a couple weeks ago, oh, don't worry, I don't use warm soap and water. I use alcohol. I said, please don't, because we know what alcohol will do. It will dry that skin. So it's great for hand sanitizing, but it's not meant to be put around our stoma. In this case here, think for a minute, what would you do around that stoma to protect it, to treat it? First of all, we want to treat the cause. Why is that punched in so much? Do they need that? It looks like she might be using convexity. And when I say convexity, the difference, the convexity, you can see this one, it's flat. Look at that bump on the back of that. That's convexity. And sometimes patients don't need that convexity. So maybe just eliminating the convexity and going with a flat barrier might take away that pressure. Those 1, 2, 3 little sores you can see, there's some yellow in them. I would wash that out. You might be tempted to put something in as a filler. So you could use an alginate, or you could use a silver product, and all the companies sell them. So you would cut a little piece of, on that case, as I'm looking for those 3, I want them to heal. You could use either. Say I chose a piece of silver. I might just cut a little piece, a little bit bigger than the wound because it can shrink. And then I would put a hydrocolloid over that piece of silver. So I would cut a piece as big or as small as you want it. And then you can put your barrier, your wafer, whichever one you're using. Remember, we're going to go with a flat. You can put that right over this, okay? And that will help with that. Okay, the most common complication is irritant dermatitis. And that's from, we talked about what's caused it and leakage. And the last thing we want is leakage. So it can take months to heal if we don't get right at it. And we want to treat the cause, fix that leak so that the person can have quality of life back and their skin back. And there's a picture there where it was leaking really bad. And what was happening is she could feel it. And if I'll say to people, did you feel any burning or anything around your stoma? Yeah, I did. I said, well, when you feel that burning around your stoma, that's a sign, take it off right away. Okay. And we want to fix it to once we determine the cause, why. And sometimes it's a matter of diet. They're eating things that they end up having a higher output, which more liquidy, more chance of leakage. So we look at their diet. We look at, okay, are you warming your flange? No. Okay, let's start with that. Or maybe we might need to add a belt. The skin barrier, is it durable? Maybe they need a little bit of convexity. Maybe this is the time they do need that with that bump on the back. And what that's going to do is going to push that stoma out further so the stool doesn't leak underneath it. It will go right into the bag. Okay? Because that's our goal, to have good wear time. And to get rid of that redness, once we've treated the cause in that, they might need a topical steroid. There it is. Yeah. And again, ignore the name, but a topical steroid can get rid of that redness. And you would spray it to the area and let it dry, and then apply your appliance. All right. Okay. Folliculitis, what is that? So it's inflammation of the hair follicles on the peristomal skin, and it's usually caused, oops, sorry. There's my picture. There we go. It's usually caused by traumatic hair removal from frequent shaving or shaving techniques. You can see all those little red dots around it. So that's what we call folliculitis. And it sometimes can have almost like pustule lesions with it. So bacterial infection causes erythema and red pustules. So think about maybe when they're shaving, I will often teach them to just sprinkle a little bit of ostomy powder around it before shaving to prevent it. And then if they're worried about nicking that bowel, say take a toilet paper roll, put that toilet paper roll around that stoma, your powder, and then you're going to shave, and then you blow off the rest of that powder because you don't want that powder to prevent your barrier from sticking when you're ready to put your appliance on. Okay. Great. Okay, so shave. You're shaving the direction of the hair, or preferably clip. You can get clippers now at stores for $20 to $30. And again, gentle removal of the wafer. You might need an adhesive remover. You might need an antibacterial skin cleansing to kill the bacteria around it. We tend to use hydrochloric acid now, which is pH friendly and very effective for redness around the skin. And you'll clean the area, but you'll put this on and leave it on for up to 5 minutes, and it really kills all that bacteria. Pat it dry and carry on. And sometimes you'll use an antifungal powder, can be rubbed onto the skin and then seal it with a no sting barrier film. Okay, Candidus is an overgrowth, a fungal organism enough to cause an inflammation, infection, or skin disease in the peristomal area. So what happens is the peristomal skin provides a warm, dark, moist environment for this to grow. Other predisposing conditions such as diabetes, use of oral contraceptives, antibiotics, chemotherapy can make us prone to these. So what are we going to do about it? We're going to eliminate the moisture, create a dry environment, antifungal powder, See if I've got a picture of it. Again, ignore the name, but it's that one there is an Arglaize powder. But what we want about that powder instead of regular stomal powder, this one has silver in it, and silver is Ag, as we know, and it kills bacteria. So this Arglaize powder will kill the bacteria. Okay. Porous tape, breathable tape, a pouch cover, and look at your barrier. So if your patient has an established pattern of fungal infections, for example, they get a history of developing a fungal rash during the antibiotic therapy, you could do prophylactic treatment as with oral diflucan might be needed. And to manage that candidiasis, use the crusting method with antifungal powder and skin prep. So crusting method means you clean your skin, pat it dry, make sure it's really dry. Then I'm gonna just sprinkle a little bit of powder on, and then I'm gonna take my barrier, my no-sting barrier, either the spray or the it'll come in a little pouch on a wipe, and squeeze it on that, and then you make it's like making a crusting. Okay, let it dry for 2 minutes, and you may choose to do another layer or two, or you may not choose. Lately, the last several years, they're not doing the level of crusting anymore. Okay, PG, that's what we're going to call this one, because I have a hard time pronouncing. It's actually pyoderma gangrenosum. So that's why we call it PG. So it's a rare inflammatory skin disease which progresses to ulcerations. The lesions have granular or crusted base, dusty red to purplish margins, can be painful. And we tend to see it in patients with inflammatory bowel disease, arthritis, leukemia, multiple myeloma. It's a condition that causes tissue to become necrotic. It leads to the ulcers and necrotic wounds, commonly on the leg, but you can see it around your stomach too. Fewer than 10,000 cases per year in Canada, and this data is a little bit old. Diseases associated with PG include Crohn's, ulcerative colitis, arthritis, leukemia, multiple myeloma, and the exact cause of PG is unknown, but it appears to be a disease of the immune system. So, and that's a perfect example of it. You can see those little wounds and you say, oh, maybe it's pressure. And to find out to do a diagnosis, they didn't have to do a punch skin biopsy to test. And there is a more severe case, another one. So what are we going to do about it? We're going to treat it systemically. Consider a steroid spray topically, manage the underlying condition, and wound care. Okay, this is quite rare. We don't see this so much. The pseudovaricose lesions or hyperplasia, and it's almost like wart-like lesions in the peristomal area. And it can be painful. We tend to see it a little bit more when we do see it with the urinary stomas because of the urine around. So you're going to look at your pouching system and what can you do to help treat that area? Good old vinegar soaks. So you'd use a tablespoon of vinegar in a cup of sterile water, mix it together, put it on the area, and that will kill that bacteria. Okay. So yeah, so we're going to be short-staffed today. So if you could just go ahead and do the work that's free, that'd be great. Sometimes we feel like that in practice. I want to share with you the other day, I've started to do some work in healthy aging. And I came in the day we started our shift, and the gentleman we were looking after, unfortunately due to his dementia, was very confused, and he swore at the poor nurse working with me, and then he took a cup of water and just threw it at her. And I said, oh my goodness. So I said to her, I said, take 10, please. And she went away. So I just want to, again, in the middle of this lecture or presentation, remind you how valuable your work is and what you do matters. And we couldn't do healthcare without you. So some complications that you're going to see in practice. Retracted stoma. Again, you can see this lady, she's sitting up and her stoma goes right in. So how can we fix that so that her output's not leaking all around? First thing I'm going to do is I'm going to put a ring around it, a stoma ring, and I'm going to show you some. Again, I'm of absolutely no affiliation with any company. I want the product that works for the patient. So with stoma ring, this one I love because it has ceramide in it. Ceramide will help heal wounds. With these rings, all the companies that sell them, it's sticky on both sides. You can tear it, mold it in. What I tend to do is I'll take a piece. I wonder if I can do this right on the screen. No, you can't see it. And I will fill it in. I'll fill in those corners like little V's where it's leaking in both sides. I might use some paste as well to catch every crease and crevice. And then I'm going to put on that warmed appliance. I may choose a convexity, something pouched out that's going to help bring that stoma out better. And here's another example of another one. You can see. The other thing, if you're having a really tough time, we have, instead of a regular ring, we have what's called a convexity ring. All three companies make them. And you can see, if you can see in that picture, how solid and hard that is. And this would be for, they come in different sizes for an oval shaped, but it's really hard. So you would put that round side to their skin, and then you would put your appliance on. And oftentimes that will work like a charm. The other thing that you're going to do is think about a belt. A belt can really help extend your wear time. There's another popular belt that's come out the last several years that I am in love with. It works so good. Here's our regular belts. There's one prong on each side, and it just connects to the loopholes on your appliance, and it clicks in with the eyelets. This is my favorite. Why do I love it? Take a peek. It's got two prongs, so each side has two prongs, so double the protection, double the hold, double the security, and oftentimes going with the two-prong belt will change that, be a game changer in terms of wear time. Because we know that having a stoma changes your quality of life, sometimes for the better. I have some people who, thank goodness they got that ostomy. But other times, especially if you're not expecting, you go in for surgery and you're not expecting to have a stoma, can be very difficult and emotional, especially if you're not having good wear time. So always be mindful of the psychological component with that. So stoma necrosis, take a peek at the one on the left. You can see that it is dark, it's dusky, and it does not look good. If you're working in a surgical area and you see that, you're gonna get another nurse to peek at that. Yeah, they can check it, and you're gonna call the surgeon right away. Because we don't want stoma necrosis. The patient would have to go back to the OR for the picture on the left to have that dead part taken out and more healthy bowel pulled forward. The picture on the right side there, you can see the brown in that. That is, but if you see on the right-hand side when you're looking at it, lots of pink healthy tissue. When we assess that stoma, although it doesn't look terrible, it's not too bad. All of that that's on one side, that yellow-brown is dead tissue, that did slough off, and underneath was healthy pink tissue. The stoma was working, putting out healthy stool, and that pink took over that hole. Okay, this one here, you can see there's too much pressure around and it's leaking, so we have to treat that. We're going to treat it, we're going to clean it and dry it really well. Look at our barriers. Is it leaking? Where is it leaking? And when you take your barrier off a patient, I always look at the back of it. And I would say, don't throw that out, let's look at the back of it. And you want to see, because you want to see, okay, is it leaking anywhere? And if it isn't, good. But if it is, that might be where we might have to put some reinforcements like the paste or the paste or a ring or a convexity ring. The other thing I didn't show you that we'll use is we'll use barrier strips. And again, it's similar to your rings, and you can tear it and mold it, and it works to help fill areas, okay? Because it appears in this picture here, I wish I could zoom that in closer, to be some open areas, I would probably be tempted to put an alginate or a silver dressing over it, a hydrocolloid, and then the barrier. We want to heal those open areas. Or if you're comfortable, sometimes if you're preventing, if we know what was wrong, we can fix that leak, if that's what it was caused from, and make sure that your barrier fits well. Okay, so pre and post. So that stoma that was retracted, or excuse me, that was necrotic, that went back to the OR. Take a peek of the picture on the right. Yay, congrats to that surgeon. Did a great job. We now have a nice healthy pink stoma. So, oh goodness, what's this? This is called stoma prolapse. So that's when you can see the top part is where the actual stoma, the opening is, where the stool comes out. And but we can see that more of the bowel has come out as well. Oh dear. So what would we do for that? So we assess the patient. How are you doing? Are you still putting output out? You're not having any pain. I might be tempted to cut my barrier a little bit bigger. And oftentimes we might have to get a bigger bag, especially if it's a prolapse like the picture we saw earlier where it's hanging down. We want to cover that. Sometimes an abdominal binder helps hold things in place, and make sure that appliance is cut large enough. Mucocutaneous separation, that's an awful big word. And what that means, and it happens with your fresher, your newer stomas. If you look at that picture, see that lower level, how it's open, you think, oh my dear, what's wrong with that? And nurses, we tend to, oh, but that will heal. So it's a post-op complication, and I would clean that area with saline, and then we'll take some ostomy powder, we'll fill it with ostomy powder, and then we'll put some paste over top, put the appliance on, and that will heal it. The other thing you could do, if you were really zealous, is you could put a piece of alginate, the product's wound care product, or a piece of silver in, cover it with the hydrocolloid and their appliance. But these areas here, monitor them, I measure them, so you have something to mark, and they tend to heal. Okay, peristomal hernia, number one complication of, stomas. So it can occur months, years after the surgery. It tends to more sooner though. Preventative measures is healthy weight before surgery. So easy for us, some of us to say. Being fit, walking, a support belt that's snug, apply it laying down. I would put that sitting up nowadays. Flexible pouching system, maybe your floating system that moves with it. Accordion flange, and I'm going to show you what I mean by an accordion flange, is that flat barrier I showed you earlier that has an accordion on the back. And it just makes it easier. The accordion will come out and push in so that you're not pushing hard on the skin. There it is, here it is. So it comes out so that we can get our hands underneath it, connect our bag, and we're not pushing down on the skin. So that's an example of one right there. Okay, I'm just noting the time. So we've talked about a lot of these. So we've talked about the rings, and you can read that. So all companies have standard and extended wear flanges. So that just means the backing that's in that skin barrier, how strong it is. And if somebody gets 7 to 8 days wear time, they might not need a stronger flange. They can go with the regular ones. Stoma adhesive versus Durahesive is the differentiate. So I think Durahesive, I think durable versus stoma adhesive. And the difference really for the patient is cost, less expensive. Disposable liners, these are a game changer. They work very well for colostomy patients. Psychologically, and I'm going to give you an example. I met the nice man who ended up, he was in Arizona in the winter time, and he has given me permission to share his story. And he ended up getting sick, needing a colostomy, and came back to New Brunswick and wanted me to check his stoma and to see. He was using a two-piece system. He was actually using the one that is with the accordion. And so it's a two-piece, goes together like a Tupperware. And he said, Nancy, he said, I've got this little lady friend that I like to take out for supper once a week. And I'm not comfortable uh, because if my colostomy goes, I got to go to the bathroom. And how do you do that in a public washroom? And I said, well, have you tried the liners? And he'd never heard of them. So what the liners do is they almost look like a little baggie, and you pop them inside your pouch. So just pop them inside your pouch. And you can get them, those are biodegradable for city septic systems. And then when you have your bowel movement, you take your two-piece system, you take that little liner, flush it down the toilet, and pop a new one in. So real game changer, much more cleaner. There's two companies right now that sell them. Again, I'm not advocating for any company, but I want you to be aware. Ativa and Colomagic, and the difference is about $20 in price. The first one is much cheaper. The second company that I listed there came out first. They both work very well. They come in a box of 100, and I recommend to patients in New Brunswick to consider ordering them online. We have a company called paylessmedical.ca. It's in Dieppe, New Brunswick, and you can get them about 30% cheaper than other areas, and especially if you're paying out of pocket. And there's other online places. So just to be aware, and that's some pictures of those. And that's me showing you how it works again. Ostomy belt, we talked about that. Okay, and this is just a tip for people who have high output. If you have a couple marshmallows before, sometimes it can slow it down. We don't use it so much anymore, but I thought I'd mention it. Filters in both drainable and closed-in pouches, and you can see that filter. I show it to you there. And that has charcoal in it. So say you pass gas, a flatus can push down on your bag without taking it apart, and that flatus will come out through that filter. You have to cover it when you're showering in that, because if you get that charcoal wet, it will deactivate it, okay? They don't work so well with ileostomies because the output is more liquidy, tends to clog it. But with the colostomy, it works great. Moldable is good for people if they have a hard time cutting. And oftentimes, once your stoma settles, if it's a regular size for a month or so, order pre-cut. Again, makes it much more easier. So when would you use a cut to fit? Would be maybe if you're not having good wear time, you've got an irregular stoma, etc. Retracted stoma, I think we've talked about how we can do that. Flush, we need to treat that skin, don't we? And at this point, we used a wide ring to help heal that skin. So we've talked about all these things here that work to help, because then we follow up with that person. How are they doing? Come see me in a week or 2 weeks, or I'm going to come see you if I'm in the community. We want good wear time for quality of life. Again, another retracted one that we talked about. Okay, so here's a question for you. Those two stomas, are they the same or are they different? It's actually the exact same patient. Again, I wanted you to show you the difference between standing and sitting. Again, that you've got an inverted one. This was a real challenge. And we added some of the rings around it to help it to heal. And I want to just touch on intimacy and life with the stoma, because usually people, if it's a cancer diagnosis and that right away, the last thing they're thinking about is intimacy. But if you have it for diverticulitis, etc., you may be thinking about that. So that's a beautiful model on the side there who actually has a stoma. And the gentleman on the left, you can see he has what's called a stealth belt. They were developed by a gentleman who loved to water ski, who ended up with a stoma, and he said, I can't water ski with this stoma. So he developed the stealth belt, and it works almost like a fanny pack, and you can get them online now. You don't have to buy his company name, but they help for activities. That cap there, oftentimes if people are going to be intimate, they'll go to the bathroom if they're using a two-piece, take off their normal bag, because the normal bag can be a little bit bulky, and they'll put on the stoma cap. And you can get all kinds of covers, just like that lady we started with. So that is the end of my presentation. I've had fun going through ostomy care with you. And this I can relate to. Sorry, I'm late. I had great nurses. So again, thank you very, very much for what you do day in and day out. We respect you, we honor you, and we thank you for the great care that you give. Happy Nurses Week to all the LPNs in New Brunswick. It's a privilege and a pleasure to work with all of you. And this is what I always end my presentations with. Who says nursing is stressful? I'm 39 and I feel great. So have a wonderful day, a wonderful week. And again, thank you for all that you do. We appreciate you. Bye for now.